So we have completed upper limb lecture 1 up to the breast, and today we will start from the shoulder joint. Okay, so shoulder joint can come as a long question too, so we will discuss it in detail. The first point is the type. The shoulder joint is a ball and socket type of joint, and it is a synovial joint, synovial variety, and the articulation. The shoulder joint articulates in the pear-shaped glenoid cavity, and to this, what is attached? The head of humerus. So if this is the glenoid cavity of the scapula, then the head of the humerus articulates here. So these both are the articular surfaces. So we have this glenoid cavity, and around this glenoid cavity we have a fibrocartilage ring called as glenoid labrum. Glenoid labrum. Labrum means lip. Okay. So glenoid cavity is shallow. Okay, it is shallow, but we want firm and more mobility. So we have to deepen the cavity. So glenoid labrum or the fibrocartilage helps to deepen the cavity. Okay. Then we will talk about the capsule of the shoulder joint. So let's say this is the humerus, and this is the head of the humerus. This is the glenoid cavity, and this is the fibrocartilage. So the capsule forms around this, around the anatomical neck of the humerus. So there is some problem in the diagram. This is the anatomical neck. So capsule will pass like this, not like this. Okay. So the capsule is attached to margin of glenoid cavity, and anatomical neck. This is important, of humerus. And we have the supports to the capsule. The capsule is supported by the rotator cuff muscles. This is for support. We'll discuss about the rotator cuff muscles in a while. Then we have the synovial lining of the joint. Every joint has its synovial lining. So shoulder joint has the synovial lining. So synovial lining lines the inner surface of capsule except on the articular surfaces. Okay. The synovial lining is absent on articular surfaces. But lines the capsule from inside. Okay, the inner surface. Synovial lining also extends as in tubular sheath around the long head of biceps. Okay, so and deep to the subscapularis also extends as the long head of biceps. Let's see this here. Extends as the tubular sheath around the long head of biceps and deep to the subscapularis muscle. So two bursas are formed. So the first bursa, this one, and the second bursa is this one. So bursa means an extension. Okay, bursa is an extension of synovial lining. So here a bursa is formed, which is called as bursa around long head of biceps. This is the intertubercular groove. Okay, this is the greater tubercle, the lesser tubercle, and all. So we know that the long head of biceps passes via this. So the bursa is formed around this, and this lies deep to the subscapularis muscle. So this is called as subscapular bursa. And this whole part, starting from here to including the subscapular bursa and here, this is the synovial lining of the shoulder joint. Okay, Then you have three ligaments here. We have an glenohumeral ligament, a transverse humeral ligament, and a coracohumeral ligament. Okay, three ligaments are there. First is glenohumeral, transverse humeral, and coracohumeral ligament. So we have these three ligaments. Glenohumeral ligament has three bands: a upper band, a middle band, and a lower band. So these three are the glenohumeral ligaments. We have a transverse humeral ligament which holds the tendon of biceps, the long head of biceps in its place, not the tendon, the long head of biceps in its place. So this is the transverse humeral ligament. The location is between the epicondyles, the greater the condyles, okay, the tubercles, sorry, greater tubercle and the lesser tubercle, okay. And this is the coracohumeral ligament which extends from the coracoid process to the greater tubercle. This is the greater tubercle, this is the lesser tubercle, and this is the coracoid process. So this is the coracohumeral ligament. The glenohumeral ligament extends from the glenoid cavity to the lesser tubercle, and the coracohumeral ligament extends from the coracoid process to the greater tubercle. Transverse humeral ligament extends between the tubercles in the bicipital groove. Okay. Then we have some secondary supports to the shoulder joint. We have two secondary supports. One is called as coracoacromion arch. We'll see the coracoacromion arch in a while. And then we have the musculotendinous cuff, which is called as the rotator cuff. Okay, we have the rotator cuff and the coracoacromion arch. So this is the diagram of the shoulder joint. We have to draw this diagram if it is asked. So let me label this one. First of all, you have to get the orientation that this is the transverse section of the shoulder joint. So this is the acromion process. This is the coracoid process. And between the acromion process and coracoid process, we have the coracoacromial arch, which is a secondary support. Okay, we have seen this, the coracoacromion arch. This coracoacromion arch may be called as the coracoacromion ligament also somewhere. Okay, then we have the muscles. This is the anterior side, this is the posterior side. So we have the anterior fibers of deltoid muscle, and we have the posterior fibers of deltoid too, posterior fibers of deltoid. Then we have the below the acromion, or you can say below the deltoid, we have the bursa. It is called as subacromion or subdeltoid bursa. So until now we have read about three bursas. One was the three bursas in shoulder joint. One was the bursa around the long head of biceps. Okay, we have, and we had subscapular bursa, and here we saw subacromion bursa or subdeltoid bursa. So there are three bursas in the shoulder joint. We can write this. Then we have the capsule. This is the capsule. This is the glenoid cavity, and this is the long head of biceps, which arises above the glenoid cavity, the supraglenoid tubercle. Then we have below the shoulder joint, we have long head of triceps too. In nerve and artery passes through it, the artery is called as posterior circumflex humeral artery, okay, which was a branch of the third part of the axillary artery, which winds around the humerus posteriorly. And we have the nerve called as axillary nerve, okay. Then we have this cuff muscles, the rotator cuff muscles. These four muscles, let me highlight them. This one, this one, this one, and this one. These four muscles are called as the rotator cuff muscles. So the first rotator cuff muscle here is called as the teres minor. The second one is called as the infraspinatus. The third one is called as the supraspinatus. And the fourth one is called as the subscapularis. Okay, so this diagram is clear. Let me quickly draw a diagram of the shoulder joint. So first you can draw the capsule here like this. Then you can draw the long head of triceps, Then a artery and a nerve, axillary nerve, and the artery is called as PCHA artery, posterior circumflex humeral artery. And we have the glenoid cavity here. Above the glenoid cavity we have long head of biceps. Then we have four muscles here. One was teres minor, the second one was infraspinatus, third one was supraspinatus, and the fourth one was subscapularis. Okay. Then we have an acromion process and a coracoid process. Between the acromion and coracoid we have coracoacromion arch or the coracoacromion ligament. We have here the posterior fibers of deltoid, We have here the anterior fibers of deltoid, and below this we have a bursa called as the subacromion bursa. So if it is clear, let's move forward. We have the relations of the shoulder joint. If you have understood this diagram, then relation is just nothing. Okay. Let's say about superior relations. So what is lying superiorly above the shoulder joint? We have the acromion process, we have the coracoid process, the coracoacromion arch, the subdeltoid bursa, and the muscle supraspinatus. So acromion process, coracoacromion arch, subdeltoid bursa, and supraspinatus. Done. Then we have the inferior relations. Let's see what is inferiorly lying. So inferior relations is long head of triceps, axillary nerve, and posterior circumflex humeral artery. Long head of triceps, axillary nerve, and PCHA. Then we have the anterior relations. In anterior relations, what we have? We have subscapularis, anterior fibers, and muscles from coracoid process. Okay. This one, the anterior side. This is the anterior side. So let's say the anterior relation is the subscapularis, this one, the anterior fibers of deltoid, and the muscles from the coracoid process. We have two muscles from the coracoid process. One we have coracobrachialis, and we have short head of biceps. So this two muscles you can write in the anterior relations to subscapularis, anterior fibers of deltoid, and muscles from coracoid process, the coracobrachialis and short head of biceps. Okay. Then let's see the posterior relations. We have the posterior relations, the infraspinatus, the teres minor, and the posterior fibers of deltoid. So infraspinatus, teres minor, and posterior fibers of deltoid. So if it is clear, the relations you can write very easily. You have to just remember the diagram. Then we want to discuss about the nerve supply. So shoulder joint is supplied by the axillary nerve and the subscapular nerve. Okay. Then we want to discuss about the movements. What are the movements that occur in the shoulder joint? So we have some 6 movements: flexion, extension, abduction, adduction, medial rotation, and external rotation. Okay. So first let's discuss about the flexion. So which muscle must be helping the flexion of the shoulder joint? So we have the clavicular fibers of pectoralis major, the fibers which are attached to the clavicle. So if it will contract, then the flexion will occur of the shoulder joint and deltoid anterior fibers. Anterior fibers of deltoid will also help in the flexion. We have some minor muscles too, like biceps, short head and coracobrachialis. Then we have extension. In extension, if flexion anterior fibers of deltoid was there, so in extension we have the posterior fibers of deltoid and a muscle called as latissimus dorsi. Okay. And the helping muscles, the accessory muscles are long head of triceps and teres major. These two muscles also help in the extension. So you have to just visualize the action of these muscles. You have the origin in insertion. So we have to just see how the muscle will contract and what will it do in the shoulder joint and right. Then we have abduction. So abduction can be of different degrees. So from 0 degree to 15 degree, we have the supraspinatus helping in it. From 15 to 90, we have middle fibers of deltoid. And for overhead, the 90 degree to 180 degree, this is the overhead abduction. We have serratus anterior and trapezius. Then we have adduction. So in adduction also pectoralis major will help, but it will the which part? The sternocostal fibers. And latissimus dorsi will also help. The helping muscles will be subscapularis and teres major. Then medial rotation. Medial rotation will be done by the pectoralis major and subscapularis. Okay. And teres major and latissimus dorsi and teres major will also help. In external rotation, we have the posterior fibers of deltoid and we have the infraspinatus and the teres minor will be helping in it. Okay. So these are the names of muscles which will help in these movements. The pectoralis major, the clavicular fibers and the deltoid anterior fibers will help in flexion. In extension, the posterior fibers of deltoid and latissimus dorsi will help. Posterior fibers of deltoid will also help in the external rotation. And in abduction, 0 to 15 supraspinatus, 15 to 90 middle fibers of deltoid. Overhead, we have serratus anterior as the main muscle and trapezius also. Adduction, we have pectoralis major, sternocostal fibers, clavicular fibers were helping in flexion, and in adduction sternocostal fibers and latissimus dorsi will also help. In medial rotation, pectoralis major and subscapularis. In external rotation, posterior fibers of deltoid, infraspinatus, and helping muscle is teres minor. Okay. So don't mug this up like in accessory muscles and main muscles. You have to just see and tell by their origin and insertion about how will they bring about the action. Then we want to discuss the topic called shoulder dislocation. So shoulder dislocation, you have to just know the direction. So it occurs mostly in inferior direction. Inferior direction, because the inferior part is the weakest. Okay, because the capsule is less prominent in the inferior direction. Okay. Sometimes surgically we call this as anterior-inferior dislocation. Anterior-inferior dislocation. Because we have the strong adductors and flexors of the shoulder. So if it gets dislocated, then the hand will come to the side of the body. Okay, close to the body. Or you can say in front of the body. So this is a normal shoulder joint here, and this is the dislocated joint. You can see this. and it has turned like this and have come to the front. So this is the anterior inferior dislocation. Okay, then we have an applied question here from the Gray's review. A 19-year-old man is brought to the emergency department after dislocating his shoulder while playing soccer. Following reduction of dislocation, he has pain over dorsal region of shoulder and cannot abduct the arm normally. Okay, the abductors are problematic here. The abduction is lost. MRI shows a torn muscle. Which of the following muscles is likely to be damaged by this injury? Okay, so from these things we can know that it is talking about the rotator cuff muscles only. Rotator cuff muscles only. So have to know which rotator cuff muscles must have been torn. So let's cross the rotator cuff muscles which are not rotator cuff muscles. Teres major is not a rotator cuff muscle. Pectoralis minor is not one. Long head coracobrachialis is not. Supraspinatus will be torn. Okay. If you don't know, let's say if you assume that this is not a rotator cuff muscle, then we have to examine the actions of these muscles. Coracobrachialis. So it extends from the coracoid process to the humerus. So if it contracts, then what will it do? It will flex the arm, and it will do adduction also. So this must likely not be damaged. Then the long head of triceps. Long head of triceps was to extension. Extension function was there to extend the elbow. So this must not be there. Pectoralis minor. It is not involved in adduction. The abduction. Supraspinatus. Supraspinatus is most commonly injured. Most common injury in shoulder dislocation. Okay. Why it is most commonly injured? Because it has an avascular tendon. So this might be the answer. And teres major does adduction and medial rotation. So this would not be the answer. So option D is our answer. Okay. After this shoulder joint, we have a small topic called as the elbow joint also. So let's discuss about the elbow joint. Elbow joint is also called as a humero-ulnar joint. Humero-ulnar joint. It is also a hinge type of joint, hinge joint, and synovial variety. Articulation is in the trochlea, the capitulum, and the trochlear notch of ulna, Okay, then we have the diagrams. Let me explain this diagram. This is the radius, this is the ulna. We have the annular ligament around the radius. This is the annular ligament. This we have drawn the humerus, the posterior end of the humerus, the inferior end, sorry. And this is the trochlea and this is the capitulum. Okay, and this is the radial fossa, and this is the coronoid fossa. So the capsule would go like this. From here it will go like this, cover the coronoid fossa also, the pulley like trochlea, and here. This will be the capsule of the elbow joint. Okay. If we see from the posterior side, this is the anterior side and this is the posterior side. If we see from the posterior side, the capsule will cover like this. It will cover this part whole, and this olecranon fossa and the olecranon process. So the capsule will go like this in the inferior part. If you don't know, let me write this. This is the olecranon fossa. and this is the radius, this is the ulna, and this process is called as the olecranon process. Okay, so the synovial lining of the shoulder joint, the elbow joint continues deep to the annular ligament. Okay, it continues deep to the annular ligament and reaches the proximal radioulnar joint. Okay. Then we have the ligaments. First one is the lateral ligament or the radial collateral ligament. The lateral or the radial collateral ligament. Okay, this extends from the tip of the lateral epicondyle. This is the lateral epicondyle and reaches the annular ligament of the radius. This is the radius, and we have this annular ligament of the radius. Okay, so this 4 which I have shown is the radial collateral ligament. These are extending in a radial fashion. Okay, we have looking at the lateral view. If you can relate, this is the lateral view. Then we have the medial ligament or the ulnar collateral ligament. So the ulnar collateral ligament has 3 bands. Here we have the medial epicondyle. So this is the anterior band, which you can see, AB. This is the posterior band, the PB, and this is the oblique band, the OB. Okay, these 3 bands AB, PB and OB form the ulnar collateral ligament. Okay, this is in triangular shaped ligament, which is the ulnar collateral ligament. So you can see the lateral radial collateral ligament, the ulnar collateral ligament here, the radius and the ulna. Okay, and you can see the annular ligament of the radius here. This is the radius, this is the ulna, and the this one. And in 90-degree flexion, the lateral view, we can appreciate the ulnar collateral ligament. Here we have all the bands. Okay, here we have the ulnar collateral ligament in a triangular fashion, and the annular ligament of radius is also visible. Okay, so let's now discuss about the muscle, the nerve supply. About the nerve supply, this is supplied by the median nerve, all the nerves, median nerve, ulnar nerve, the radial nerve, and the musculocutaneous nerve also. Okay, about the relations, we can think of the anterior relations. So let's say, what is the anterior relation? The roof of the elbow joint. The roof of the elbow joint means the elbow joint just lies deep to the cubital fossa. Okay, think of cubital fossa. So what was there in cubital fossa? We have brachialis, the biceps tendon, the brachial artery, median nerve, bicipital aponeurosis. Okay, then the posterior relation must be lying deep to the elbow joint. We have the triceps brachii muscle. The lateral relation is common extensor tendon and supinator muscle. Supinator muscle generally has wounds around like this. And the medial relation is the ulnar nerve. Okay, so medially we have the ulnar nerve, and laterally we have the common extensor tendon and supinator muscles. Okay, then there are 2 types of movements in the elbow joint: flexion and extension. So flexion is done by brachialis, biceps, and brachioradialis. Brachioradialis is the weak flexor because its origin is very far located. And we have extension. For extension, we have triceps and a very small muscle called as anconeus. Okay, then we have the elbow dislocation. In clinical anatomy, we have the elbow dislocation. So elbow dislocation most commonly occurs in the posterior direction, and is generally associated with the fracture of coronoid process. If the coronoid process is fractured, then the elbow dislocates in the posterior direction because the force transmission is in that direction. Then we have a condition called as pulled elbow. Okay, generally occurs in children because the head of radius is not yet developed much. So the annular ligament, this is the head of the radius, the annular ligament will be loose here because there is not commonly dislocated. ठीक है, तो पुल्ड एल्बो क्यों होता है? क्योंकि रेडियस का जो डेवलपमेंट है वो अब तक हुआ नहीं है. सो रेडियस इज नॉट येट डेवलप्ड, so annular ligament is loose. So this is pulled elbow. Okay, then we will start discussing the next topic, that is forearm. And about the forearm muscles now. Up to here we have completed the elbow joint and the shoulder joint, and now we are going to the forearm muscles. So there are a lot of muscles in the forearm but we'll cover it part by part and with the atlas images also. So we have the anterior compartment. Anterior compartment generally contains flexor muscles, so this is called as the flexor compartment. We have the superficial group and the deep group, which are present superficially and deeply. So in superficial group we have the pronator teres, the flexor carpi radialis, the pronator longus, the flexor carpi ulnaris, and the flexor digitorum superficialis. Sometimes this muscle is put in the intermediate group, but we put it in the superficial group only. Pronator teres, flexor carpi radialis, then the palmaris longus, flexor carpi ulnaris, and flexor digitorum superficialis. In the deep group we have the flexor digitorum profundus. Profundus means deep. Okay, profound means deep. The flexor pollicis longus and the pronator quadratus, which is the deepest. Okay, flexor digitorum profundus, flexor pollicis longus, and the pronator quadratus. So now we will see these muscles. Look this, the flexor digitorum superficialis. Okay, so we have two heads. We have an humero-ulnar head, this is the humero-ulnar head, and the radial head, this is the radial head, and the FDS, the flexor digitorum superficialis, then passes deep to the tendons pass deep to the flexor retinaculum and divides into four distinct tendons. Okay, so this is generally a pouch like muscle. So here the two things that pass will be the ulnar artery, like this. It will pass deep to this muscle. This is the ulnar artery, and we have along with it the ulnar nerve, the ulnar nerve also, that will pass deep to this. Okay, then we have some muscles visible here. It is the biceps brachii, the triceps brachii, the brachialis visible here. This is the brachialis, which lies deeply, and the medial epicondyle of humerus. This is the brachioradialis. The brachioradialis, you must know that it forms the lateral boundary of the cubital fossa, and the pronator teres, which forms the medial boundary. This is the cubital fossa. Okay, but we have to see the muscles. This one, the pronator teres here, the brachioradialis. Brachioradialis is not a muscle of the forearm, it is a muscle of the arm. So first is pronator teres. So here is the pronator teres, which forms the medial boundary of the cubital fossa. Then we have the flexor carpi radialis here. This is the flexor carpi radialis. The tendon of flexor carpi radialis reaches the index finger. Okay, then we have the palmaris longus. The palmaris longus is a long tendon. The long tendon passes over the palmar carpal ligament and terminates here. This is the tendon of palmaris longus. This is a really long tendon. Then we have the flexor carpi ulnaris here. Flexor carpi ulnaris. This is the flexor carpi ulnaris here in the ulnar side. Okay, so we have the brachioradialis. So if here is the forearm, we have the brachioradialis here. Then we have the pronator teres here. Then we have the flexor carpi radialis, we have the pronator longus and the flexor carpi ulnaris. Okay, so this is the arrangement of muscles from the radial side, from the lateral side to the medial side. Okay, so we have discussed this. And the flexor digitorum superficialis I have shown here, it lies deep to these muscles. Okay, it lies deep to these muscles. And we have the deep muscles, the flexor digitorum profundus, flexor pollicis longus and pronator quadratus. Okay, so here we have the flexor digitorum profundus, and it is also divided into 4 tendons, 1, 2, 3, and a long tendon which goes in the middle, the little finger. Okay, this is the flexor digitorum profundus. The flexor pollicis longus, comes like this, and the tendon goes to the thumb. The pollicis means the thumb, and the pronator quadratus is a quadrangular muscle. It is a quadrangular muscle. Okay, then we have to talk about the origins. The flexor compartment, has a common flexor origin. The origin is common for all the superficial and the deep group muscles, and the common origin is the medial epicondyle of humerus. This is the common flexor origin. So this all originates from the medial epicondyle of the humerus. Okay. Okay, for the superficial muscles. Okay, for the deep group muscles the origin will be different. Yeah. So pronator teres, let's discuss about the pronator teres. Pronator teres originates from medial supracondylar ridge. Okay, originates from the medial supracondylar ridge. And inserts to the lateral to the shaft of radius. Okay, inserts laterally to the shaft of the radius. Insertion is lateral to shaft of radius. It has 2 heads. Pronator teres has 2 heads. One is the superficial head and another one is the deep head of the pronator teres. Okay, and about we have the medial epicondyle of humerus, common flexor origin. I have said that. Then we have the flexor carpi radialis. Flexor carpi radialis is attached to carpal bones, attached to the carpals. The palmaris longus, ultimately form the palmar aponeurosis here. Palmaris longus forms the extends as the palmar aponeurosis. And the flexor carpi ulnaris present in the ulnar side and goes to the carpals. It inserts to carpals. Okay. Let's discuss about the deep muscles. We have the flexor pollicis longus. Flexor pollicis longus origins from anterior surface of ulna. Anterior surface. This is the ulna. This is the radius. Anterior surface of ulna. This is the anterior surface of ulna. Originates from the anterior surface of ulna. Okay, and goes to the thumb, the pollicis. Then we have the flexor digitorum profundus and the pronator quadratus, which is the deepest muscle. I have said that. Okay. Okay, this is the flexor compartment. Then we are moving to the extensor compartment of the forearm. We have the superficial group of muscles, that is brachioradialis. Okay, the brachioradialis. Here we saw the brachioradialis also, but it is the group that is present posteriorly. Okay, this muscle is like this, turning back, so it is counted in the deeper group. Okay, this is the brachioradialis here. Brachioradialis, I will show the diagram later. Then we have the extensor carpi radialis longus, extensor carpi radialis brevis, extensor digitorum, extensor digiti minimi, extensor carpi ulnaris. Okay, we have the brachioradialis, the ECRL, ECRB, the extensor digitorum, the extensor digiti minimi, and the extensor carpi ulnaris. Okay, minimi here means little finger. Then we have the deep muscles of the back of the forearm. We have the supinator muscle, the extensor indicis, extensor pollicis longus, extensor pollicis brevis, and the abductor pollicis longus. ठीक, supinator, extensor indicis, EPL, EPB, and APL. Okay, these are the deep group muscles. So let's talk about the posterior part. This is the surface anatomy. This is the olecranon. Okay, this is the brachioradialis here, the forming a prominence here in the lateral side. We have the flexor carpi ulnaris here. The extensor digitorum is present here. Then extensor carpi ulnaris in the ulnar side. The abductor pollicis longus, which abducts the thumb. Okay, abductor pollicis longus, and here in the prominence we can see the extensor digitorum tendons. Okay, then we will look at the atlas image here. Between the radius and ulna we have the interosseous membrane, and in the interosseous membrane the radius and the ulna divides it into anterior compartment and the posterior compartment. Here we have an intermuscular septum also. This is not important much. Look here, we have the brachioradialis here. Here the brachioradialis is extending here, 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 and up to this. Okay, the brachioradialis. Then we have a muscle called as the anconeus. Anconeus muscle is a small muscle present over here. Okay, this is the anconeus, and we have extensor okay, and anconeus is done. Then we have this muscle. Just look at this. Let's erase this. Extensor carpi radialis longus. Extensor carpi radialis longus. ECRA is present here. Extensor carpi radialis brevis. ECRB is also present here. ECRL, see that it is going long, but ECRB terminates shortly. The origin is nearer. Okay, but for ECRL the origin is far. Brevis and longus. Brevis means small and longus means long. Okay. Then we have this large muscle here, which is called as the extensor digitorum. Here we have the tendons of extensor digitorum 1, 2, 3, and 4. 4 tendons. The 4 tendons extend like this. Okay. Another muscle in the anterior compartment which was having tendons. This flexor digitorum profundus tendons are also present here. Okay, the FDS tendons. Here we have FDS tendons. Here we have extensor digitorum tendons. Okay, we have a muscle here, adductor pollicis longus here, which terminates in the thumb. Okay, adductor pollicis. We have extensor pollicis brevis also. Here we have the tendon of extensor pollicis brevis also. Okay, this is the extensor retinaculum, which other muscles are visible here. We have this extensor digiti minimi here, extensor digiti minimi, which is going like this to the little finger. Okay, and the extensor carpi ulnaris here. This is the ECU, extensor carpi ulnaris, which remains on the ulnar side and goes to the little finger. Okay, and we have the flexor carpi ulnaris also here, flexor carpi ulnaris. Okay, so if you have understood all this, the attachments of ECRL and ECRB are somewhat important. The ECRB attaches to the second metacarpal, and the ECRL attaches to the third metacarpal. Okay, this is the attachment. Okay, so please look at these muscles. These are the superficial muscles of the forearm, the posterior compartment. Okay. Here is a smaller diagram also. Here we have the anconeus muscle, the brachioradialis muscle. We have this extensor carpi radialis longus, extensor carpi radialis brevis, the extensor digitorum, okay, the extensor digiti minimi, and the extensor carpi ulnaris. Okay. It is very difficult to identify these muscles based on the dissection pictures. So you have to just identify the muscles by the tendons. Of course, you can mix up the tendons and it gets difficult to identify this. Okay, sometimes. Then we have the deep muscles of forearm. Here you have the deep muscles of forearm. Let's look at the deep muscles. Brachioradialis was a superficial muscle. Okay. Here we have the supinator muscle. Here we have the supinator muscle here. Okay, deep head of supinator. We have two heads. The superficial head is lying like this, and the deep head will turn like this. Okay. The supinator generally like wounds around the ulna. Okay. This is the supinator muscle like this. And the interosseous membrane is present. Okay. The pronator teres is a superficial muscle. Then we have adductor pollicis longus, APL here, adductor pollicis longus here, and it terminates in the thumb. The extensor pollicis brevis also present here. Okay, APL and EPB tendons are here. Extensor indicis, which goes to the index finger, terminates in the tendon as an index finger, and the extensor pollicis longus also present here, which terminates in the thumb as well. Okay, EPL, EPB, APL, and extensor indicis. Okay, so in the deep compartment we have supinator, extensor indicis, EPL, EPB, and APL. These 5 muscles. We have seen the supinator, extensor indicis. We have seen, I hope, extensor indicis, EPL, APB, EPL, APL. Okay, all the muscles are demonstrated here. Okay. Here we have a clearer diagram also. This is the supinator, the superficial head, and the supinator, the deep head, and the adductor pollicis longus here, the extensor pollicis brevis here. APL tendon and EPB tendon are just going together. Okay, we'll see in the boundaries of the anatomical snuff box also after this topic. Then we have the extensor pollicis longus tendon here, which is going to the thumb, and the extensor indicis also, which is going to the index finger. Okay, we have the 5 muscles of deep compartment and posterior compartment of the forearm. Okay. Then we have to discuss a concept called as the supination and pronation. Pronation and supination. We have an axis. Okay, we have an axis here passing from the head of the radius to the articular disc of the inferior radio-ulnar joint. Okay, it passes from the axis passes from the head of the radius, radial head, to articular disc of inferior radio-ulnar joint. Okay, articular disc of inferior radio-ulnar joint. So in the pronation supination, head of the radius, the radial head, okay, the head of this radius rotates within the annular ligament. Here we have the annular ligament, so head of the radius rotates within the annular ligament. Okay, so in pronation, the lower end of ulna, this is the ulna, so the lower end of the ulna goes posterior-laterally. Okay, it goes posterior-laterally in pronation. Pronation, ulna lower end goes posterior and laterally so as to pronate the arm. Okay, for supination, the lower end of the radius goes anterior-medially. Okay, anterior-medially. Okay, here we have the articular disc and the fibrocartilage, which is also called as the TFCC, the triangular fibrocartilaginous complex, TFCC. Okay. According to strength of the movement, the supination is a stronger movement. Supination is stronger than the pronation. Okay, because supination is a level with screwing movement. Okay, for pronation we have the muscles, the name of the muscles, that is pronator quadratus. This is the main muscle for for pronation, and the pronator teres when it is against the resistance, For supination we have the muscle which is supinator when the elbow is extended, and the biceps brachii when the elbow is flexed. Okay, then we have a term called Volkmann's ischemic contracture. It occurs due to fibrosis of majorly flexors of forearm. So when the flexors of forearm are fibrosed, the thing called is Volkmann's ischemic contracture. The most common cause is the injury to brachial artery. The brachial artery in supracondylar fracture. Brachial artery injured in supracondylar fracture of humerus. Okay. The flexor muscles are generally paralyzed or fibrosed. Then we have the concept called as the anatomical snuff box. You may be seen the people taking that ganja or the drug between the anatomical snuff box. Like snuff is related with the drugs. Okay, the compounds which are addictive. Okay, the anatomical snuff box. So anatomical snuff box is a type of like depression here between the tendons of APL, EPB and EPL, and the content of the anatomical snuff box is radial artery. Radial artery is present here. So let's discuss about the anatomical snuff box. In anatomical snuff box we have the tendon of APL and the tendon of EPB, which form the lateral boundary, and the tendon of EPL which forms the medial boundary. The floor the floor is formed by the bones, the scaphoid, the trapezium and the base of first metacarpal. Okay, and the floor is also formed by the tendons of ECRL and ECRB. We have seen the tendons of ECRL, the extensor carpi radialis longus and the extensor carpi radialis brevis also passes through the thumb. So floor is also formed by ECRL and ECRB tendons, and scaphoid, trapezium and base of first metacarpal. This is the floor. Okay, the roof of course will be formed by the skin, the superficial fascia. The another thing which I want to say is the cephalic vein. The cephalic vein also forms its roof, and the superficial branch of radial nerve. These two contents you must have read in the cubital fossa. Okay, so roof is formed by the cephalic vein and the superficial branch of the radial nerve. Clear? And the content is the radial artery. You can see the radial artery clearly passing. So content is the radial artery. So this is about the anatomical snuff box, and now we'll start a topic called as the extensor retinaculum. We have a flexor retinaculum and an extensor retinaculum. So we'll discuss the extensor retinaculum first. So let's start the extensor retinaculum. It has 6 compartments. So make a fist and we take a transverse section through the fist. So we have the 6 compartments here, 1, 2, 3, 4, 5 and 6. Here in the lateral side we have the radius and the ulna. Okay. So in the first compartment we have EPB and APL tendons. Okay, the cross section of EPB and APL tendons. Then in the second compartment we have the ECRL tendon and the ECRB tendon. Okay. In the third compartment we have the extensor pollicis longus tendon. This is in the third compartment. In the fourth compartment we have a long tendon of extensor digitorum and extensor indicis also. Extensor digitorum and extensor indicis tendons. And two more things, that is posterior interosseous nerve and anterior interosseous artery, PIN and AIA. Okay, posterior interosseous nerve and anterior interosseous artery too in the fourth compartment. Okay. In the fifth compartment we have extensor digitorum minimi tendon. Okay, the fourth compartment we have extensor digitorum minimi tendon, and in the fifth compartment we have extensor carpi ulnaris tendon, ECU, in sixth compartment. Okay, this is in the fifth. This EDM tendon is in the fifth and ECU is in the sixth. Okay. So these are the compartments of extensor retinaculum. Okay, and this is the lateral side and this is the medial side. Understood? So let me revise the things. So first one is the anatomical snuff box we discussed. That is the two things that are forming the lateral wall. The lateral boundary are APL and EPB tendons, external pollicis brevis and adductor pollicis longus tendon. This is the lateral boundary. In the medial boundary we have EPL tendon, extensor pollicis longus tendon in the lateral boundary. We have the roof that is formed by the skin, the superficial fascia, the cephalic vein, and the content, that is lateralmost content of the cubital fossa. Yeah, the superficial branch of radial nerve. These are forming the roof. The floor is formed by the bony things, that is scaphoid, trapezium, base of first metacarpal. These are forming the floor of the anatomical snuff box. The roof, floor, the lateral wall and the medial wall are done, and the content is the radial artery going through this. Okay, and when I talk about the extensor retinaculum, we have 6 components. That is, the first one is the radial cross section and the ulnar cross section U. Okay, we have this compartments here, 1, 2, 3 and 4, 5 and the 6. Okay, these are the walls. This is the retinaculum and the projections here to the radius and ulna, which are forming the components. This is the 1, 2, 3, 4, 5 and 6 components. Okay, so in the first one, what are present? The EPB are present and APL is present. That is forming the lateral wall of the your anatomical snuff box. Here what is present? The ECRL and the ECRB are present. That is forming the floor of anatomical snuff box. Okay, here what are present? The EPL tendon is present. EPL, what is this? This is the medial wall of anatomical snuff box. Okay, you can remember this. This is the first component, the first, second, the third compartments. And the fourth compartment, in the fourth compartment we have the big tendon of extensor digitorum, the small tendon of extensor indicis, and two more things I said, that is posterior interosseous nerve and anterior interosseous artery. In this we have the extensor digiti minimi tendon, and in this component we have extensor carpi ulnaris tendon, because this is the ulnar side. Okay, this is the EDM and this is the ECU. This is the lateral side and this is the medial side. So this is the extensor retinaculum with the 6 components in the 6 compartments. This is the anatomical snuff box. I talked about pronation, supination, the muscles of forearm. Let me revise the muscles of forearm too. Anterior compartment, posterior compartment, flexor compartment, extensor compartment. In the superficial group we have pronator teres, the flexor carpi radialis, pronator the longus. Okay, the flexor carpi ulnaris and the flexor digitorum superficialis. In the deep group we have flexor digitorum profundus, flexor pollicis longus and the pronator quadratus. In the posterior compartment, in the superficial group we have brachioradialis, ECRL, ECRB, ED, EDM and ECU. extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris. In the deep group, we have supinator, extensor indicis, EPL, EPB, and APL. Okay. I hope you understood. So after extensor retinaculum, we wanna move to the flexor retinaculum. So let's discuss the flexor retinaculum now. Before discussing the flexor retinaculum, as it is covering the carpals and the attachments are in the carpal bones, so in projections of carpal bones. So I want to discuss the osteology a bit of carpal bones. So these are the carpal bones present over here. This is the scaphoid, this is the trapezium, the lunate, and the pisiform bone. Okay, this is the triquestrum and the pisiform. Okay, this is the trapezoid, the capitate, and the hamate. Okay, this is the hamate. So these are the 8 carpal bones, and these are the things that are present over here. Okay. So after this, let's see the bony projections of what are the attachments of the flexor retinaculum. So this hamate has a hook. Okay, this hook like projection in the hamate bone. This hamate has a hook to which the flexor retinaculum is attached. This pisiform, this is one of the attachments of the flexor retinaculum. This trapezoid, this trapezium has a crest. Okay, this trapezium has a crest like this. This is the crest of trapezium, and the scaphoid has a tubercle like thing. This is the tubercle. This is the tubercle of scaphoid. These are the things to which the flexor retinaculum is attached. The 4 projections: the hook of hamate, the pisiform bone, the crest of trapezium, and the tubercle of scaphoid. So let's see in the diagram here. So this is the blue structure is the flexor retinaculum, and we have the projections. Let's label them. This is the hook of hamate. This is the pisiform bone. This is the crest of trapezium, and this is the tubercle of scaphoid. Okay, and these all are the things that are present here. We have the tendon of palmaris longus. This is the tendon of palmaris longus present here. This whole thing is the tendon of palmaris longus. Okay, then we have this artery which is called as the radial artery. So we have a branch of radial artery going superficial to the flexor retinaculum. This is the superficial branch of radial artery. The superficial branch of radial artery. We have a nerve here. This is the median nerve. So median nerve divides into 2 parts. The deep part goes there, and this one is the palmar branch that is coming over the flexor retinaculum. Palmar branch of median nerve. Okay, this is the palmaris longus tendons, which passes superficially to the flexor retinaculum. Then we have 2 other structures. This one is the ulnar artery, which passes over the flexor retinaculum, and this one is the ulnar nerve. This one is the ulnar nerve, and the branch that is passing over it is the palmar branch of ulnar nerve, and there is a ligament here that is hamate ligament. Okay, this is the pisohamate ligament that is present over here. So this is the section that I am talking about. If we chop up the palm in this direction, then the structures that will be present like this. Okay. Not this structure, but if you chop the palm like this, then the structure formed will be like this. Okay, this is just the structures that are passing superficial and deep to the flexor retinaculum. So that may be a question in the exam, like what structures pass superficially to flexor retinaculum. So you have to write all this. Okay, what are the attachments, you can write all this. What is the extent, you can write the bony projections and the extent. Okay, questions may be like that, like what branches of what two nerves pass superficially to flexor retinaculum, you can write. Tendons of Dax pass superficially to flexor retinaculum, you can write. Okay, so let's see at a cross section through the the flexor retinaculum. So this one is the flexor retinaculum. Okay, it has two slips, a superficial slip below which, deep to which two a artery and a nerve pass, that is the ulnar nerve and the ulnar artery. Here you can see the ulnar nerve and the ulnar artery, palmar branch of ulnar nerve and the ulnar artery here. So if you just chop, you can see that in below the, just below the superficial slip of the flexor retinaculum. We have the deep slip of the flexor retinaculum. This is the deep slip of the flexor retinaculum, and here we have the FPL tendon, flexor pollicis longus tendon, and the bursa around the flexor pollicis longus tendon is called as the radial bursa. Just remember this. What we have here? Here we have the median nerve passing just below the flexor retinaculum. Let's say we have a compression of the median nerve here. If the median, so I was telling that if the median nerve is compressed below the flexor retinaculum, let's say some injury is there and the median nerve is compressed here. The median nerve is compressed just below the flexor retinaculum. There is a condition which is called as the carpal tunnel syndrome. Okay, so you must know about the carpal tunnel syndrome, that is the compression of median nerve just below the flexor retinaculum. Okay, and here we have the FDP tendons, and here we have the FDS tendons. We know FDP and FDS tendons are also 4 in number, so 4 tendons of FDS, 4 tendons of FDP, and there is also a bursa surrounding both. Okay, so here we complete our flexor retinaculum. So let me first revise your flexor retinaculum a bit. Okay, let us revise them. So I said the flexor retinaculum has 4 attachments. One is the hook of hamate, and the second one is the pisiform bone, the crest of trapezoid, and the tubercle of scaphoid, Okay, tubercle of scaphoid, crest of trapezium, hook of hamate, and the pisiform bone. And here we have the pisohamate ligament. Here we have the pisohamate ligament also. Okay, then let's say this is the flexor retinaculum. Here we have the flexor retinaculum. Okay, so here we have the palmaris longus tendons, 4 palmaris longus tendons. Here we have the artery which is known as the radial artery. In the anatomical snuff box give us the branch that is passes superficially, that is superficial branch of radial artery. Okay, we have a nerve called as the median nerve. The median nerve passes deep, but a branch passes superficially, that is the palmar branch of median nerve. Okay, there is a palmar branch of median nerve. Here we have a nerve and artery. Here we have the ulnar artery. And the ulnar nerve also. Here we have the ulnar nerve, and a branch of ulnar nerve also passes. Here is the superficial branch, the palmar branch of ulnar nerve. Now, so these are the structures, and let's discuss about the cross section too of the palmar the flexor retinaculum. So here let's draw the carpal bones here first, the cross section of the carpal bones. Okay, I drew the cross section of the carpal bones. And let's attach the flexor retinaculum now. So this is the flexor retinaculum. I said there is a deep slip, sorry, superficial slip here. There is a deep slip which extends deeply. Below the superficial slip we have two structures. I said that is the ulnar nerve, and that is the ulnar nerve and the ulnar artery. Okay, we have the tendons are FDS because it is superficial, so I will draw it first. Then the tendons have FDP which lies deep. These are the tendons, and here you have tendon of FPL and a bursa surrounding it, that is called as the radial bursa. That is the radial bursa, and here we have the nerve called as the median nerve, and I said that compression of median nerve leads to a syndrome called as carpal tunnel syndrome. So this is the your flexor retinaculum. After flexor retinaculum, we'll move forward. After that, let's discuss about the muscles of the hand. Okay, it is considered a difficult topic also. Muscles of the hand, I don't have currently the pictures of the muscles of the hand like the atlas images, but I will try to draw the schematic pictures so that you understand all the muscles. Okay, so there are 20 muscles, so I group it into 4 classes. One was the thenar muscles, the hypothenar muscles, okay, the lumbricals and the interossi. Okay, so what are thenar muscles? You know that in our hand like this, if it is our hand, then there is 2 eminences. This is the this is the thenar eminence, the eminence that is formed by the thumb, and the eminence formed by the middle little finger is the hypothenar eminence. So muscles present in this thenar region are called as thenar muscles. So we have 4 thenar muscles: abductor pollicis brevis, flexor pollicis brevis, opponens pollicis and adductor pollicis. Adductor pollicis is considered a thenar muscle, but it is not present in the thenar eminence. In thenar eminence we have APB, FBB and opponens pollicis. Okay, adductor pollicis belongs to the thenar muscle group, but it is not the muscle that is present in the thenar eminence. Okay, abductor pollicis brevis, flexor pollicis brevis and opponens pollicis are supplied by the median nerve, and the adductor pollicis is supplied by the ulnar nerve. Okay, just remember this. Then we have the hypothenar muscles. Hypothenar muscles, we have the minimi muscles, adductor digiti minimi, abductor digiti minimi, sorry. Then we have the flexor digiti minimi, then opponens digiti minimi, and 4 is the palmaris brevis. Palmaris brevis is a subcutaneous muscle. So if you remove the skin in dissection hall, you can see the some parts of the fibers of the palmaris brevis attached to the deep fascia. So palmaris brevis is the only subcutaneous muscle that is present. Okay, all these are supplied by the ulnar nerve. Okay, the hypothenar muscles are supplied by the ulnar nerve. After this we have 4 lumbricals and 8 interossi. Okay, there may be palmar interossi and dorsal interossi, and we have lumbricals. Lumbricals mean worm like. Okay, worm like, and interossi means between the bones. Between the bones we have interossi. So these are the muscles. Now let's discuss about the hypothenar and thenar muscles in a diagram. So let me draw a diagram. Let me draw a diagram in good notes so that we understand it well. Let's say this is the thumb and 2 phalanges here. We have 3 phalanges in the all the fingers, and in the thumb we have 2 phalanges. So I will draw the phalanges here. So let's say this is the bony framework of the hand, and in this we will go to the medial to lateral side. So this is the medial side and this is the lateral side. So we will discuss about the attachments of all the muscles here. These are the carpal bones. If you want me to label them, so I will label this is the hamate, this is the capitate, the trapezoid, the trapezium, and the pisiform bone, the the scaphoid, lunate, and the triquestrum. Okay, so these are all the bones, and we have the flexor retinaculum extending between them like this. We know that flexor retinaculum attaches to the hookup hamate, the pisiform bone, the crest of trapezoid, and the tubercle of scaphoid. Okay, this is the flexor retinaculum. So now we will mark all the first we will go about the thinner muscles. So let's mark the thinner muscles. Let me erase all this stuff that is present here, so that you can get a clean image here. Okay, let's label them now. So I will do this in blue color so that it will be visible. So first muscle, let's take abductor pollicis brevis. Okay, abductor pollicis brevis generally attaches to the trapezium and scaphoid, this part. Okay, so it goes to the metacarpal of the thumb. Okay, it goes to the metacarpal of the thumb, this one. Okay, this is the like this. Then we have the flexor pollicis brevis, which also starts here and goes this, but it is present in a bit laterally, and the opponens pollicis just starts and ends in the base of the metacarpal of the thumb. Okay, so let me label these all. I will label it later on. Okay, then let's talk about the adductor pollicis. Adductor pollicis is a big muscle, so it has two origins, two heads, transverse head and oblique head. So the oblique head starts from the capitate and the trapezium. Okay, like this. Generally you can say the capitate and the base of the first metacarpal of the index finger. Okay, starts like this and goes to the metacarpal of the thumb. So this is the oblique head of the adductor pollicis, and the transverse head starts in the metacarpal of the middle finger and goes to this phalanges of the proximal phalange of the thumb. Okay, this is the transverse head. So let me label all the thinner muscles. This muscle is the opponens pollicis. This one is the adductor pollicis brevis. This is the flexor pollicis brevis, that is a bit laterally present, and the two heads of this both muscle are adductor pollicis. This is a transverse head, and this is the oblique head. And the radial artery, this is the radial artery present between the which is present between transverse head and oblique head of adductor pollicis. Okay, after this let's go to the thinner muscles, the hypothinner muscles, after finishing the thinner muscles. So about the hypothinner muscles, generally start from this portion. This muscle, which attaches to the base of the metacarpal of the little finger, is called as the opponens digiti minimi, small muscle, which helps the opposition of the name itself suggests the action, opposition of the little finger, and the part which goes from the junction of the hamate and the pisiform. Okay, and goes to the proximal phalanx here of the little finger, that is flexor digiti minimi, and bit laterally present is the abductor digiti minimi, which goes to the same part. So these are all the hypothinner muscles that are present. Okay, the thinner and the hypothinner muscles. I hope you saw the attachments as well. Okay, then we want to talk about the lumbricals, the lumbrical muscles. Okay, So they are 4 in numbers. They originate and insert in tendons only. So they have tendinous origin as well as tendinous insertion. So lumbricals are designated by L. So we have L1, L2, L3 and L4. Just take a note that L1 and L2 are unipinnate. Their fibers are in one direction only, unipinnate muscle, and they are supplied by the median nerve. The L3 and L4 are bipinnate, and they are supplied by the ulnar nerve. Okay, so let's draw the lumbricals as well. I will draw it very quickly. So let's say this is the hand, this is the little finger, the ring finger, middle finger, index finger, and okay, now it's fine. Yeah, so after this, let's draw the tendons of flexor digitorum profundus also. So here we have a tendon of FDS, here we have a tendon of FDS, here we have a tendon, and here we have a tendon. What are these? These are the tendons of FDP, sorry, FDS I said, FDP, flexor digitorum profundus tendons. Okay, so here we have the lumbricals attached. So let's draw the lumbricals. This one, the first lumbrical here, this is the L1 lumbrical which gets attached here. The L2 lumbrical, I said L1 and L2 both are unipinnate, that's attached here. We have L3 lumbrical here, like this. This is the bipinnate lumbrical L3 which gets attached here, and we have the L4 also bipinnate lumbrical, it's attached here. Okay, these are the lumbricals L1, L2, L3 and L4. Okay, where it is getting inserted, this is getting inserted in the dorsal digital expansion of extensor digitorum tendons. Okay, extensor digitorum tendons have a dorsal digital expansion. These are also tendinous insertion only, so they insert here. All the lumbricals insert in dorsal digital expansion of extensor digitorum tendons. Okay, then the function. What are the functions of lumbricals? Lumbricals help in flexion at MCP, extension at ICP, interphalangeal joint. Okay, flexion at metacarpophalangeal joint and extend at interphalangeal joint. Okay, so these are about the lumbricals. I said there are 4 lumbricals. L1 unipinnate, L2 is unipinnate, that attaches to this finger. L3 attaches is bipinnate and attaches here to the dorsal digital expansion of ED tendon, and L4 also. Okay, next we will talk about the interossei muscles. Okay, interossei. 8 in number, that is 4 palmar interossi and 4 dorsal interossi. Okay, 4 dorsal and 4 palmar are there, and 4 palmar and 4 dorsal are both all are supplied by the ulnar nerve. Okay, ulnar nerve as the supply the interossi. Interossi are generally used in the finer movements, like if you are playing the keyboard or the piano. So ulnar nerve, that for the same reason that it is the main nerve of hand. Ulnar nerve is the main nerve of hand. Okay, so ulnar nerve also is known as musician's nerve because it is helping in the fine movements. Okay, the fine movements. So mnemonic for interossi: PAD, DAB. What is PAD and DAB? The palmar interossi help in adduction. Okay, and the dorsal interossi help in abduction. Clear? So PAD and DAB. These are there. So let me tell you that palmar interossi are unipinnate. Palmar interossi are unipinnate, and the dorsal interossi are bipinnate. Okay. So what is abduction and adduction? Let's say this is our hand. So here we have an axis passing through the middle finger. The axis is the middle finger. If you just bring your fingers towards the middle finger, then it is called adduction, and if you bring the let go the fingers away from the middle finger, all the both in opposite directions, then it is called as the abduction. So the actions of adduction and abduction of fingers is done by the interossi. Okay. So let's discuss about the palmar and the dorsal interossi in two separate diagrams, as in one diagram it may be get complicated and all. Okay. Let's discuss about them both. So I have to draw a diagram, then we'll copy and paste the diagram, two parts. Let's draw only the metacarpals here of the four fingers. Okay, and the metacarpal of the thumb. It is not so pretty, but we'll manage it. And the two phalanges here, three phalanges here, three phalanges here, three here, and three here. Understood? So this is the hand, the bony framework. You copy this, paste this here. Okay. We have to discuss the palmar interossi as well as the dorsal interossi. So this is the palmar and this is the dorsal interossi. We'll discuss this. Okay, in both these diagrams. Let's talk about the dorsal palmar interossi first. So this is the middle finger. This is the axis. Okay, this is the axis. So let's draw the palmar interossi. So first palmar interossi is in the thumb here, and it attaches to the proximal phalanx. This is the P1. P1 is unipinnate. Of course, all palmar interossi are unipinnate. Then we have P2. Here we have P2, and it attaches to the proximal phalanx also. Middle finger has no palmar interossi. No palmar interossi in middle finger. So if the middle finger is lost due to some reason, then palmar interossi muscles are not affected. Okay. So if a question is that if a person loses his middle finger, then does the adduction power is lost? No, the adduction power will be unaffected because of no interossi present on the palmar interossi. Then we have the P3. Here we have P3 inserted here, and we have the P4 inserted here. Okay, the P1, P2, P3 and P4. Okay, these are the axes. This P1 can also be absent because we have already the adductor policies for this. So this is just rudimentary, but it is present in most of the individuals. Okay, then we will talk about the dorsal interossi, which are a bit complicated than the palmar interossi. So we will talk about the dorsal interossi also. So these are bipinnate. So we will draw the dorsal interossi one here between the thumb and the index finger. This is the D1. It gets inserted in the index finger proximal phalanx. Okay. Then we will discuss about the D2. This is the D2, gets inserted in the proximal phalanx of the middle finger. Okay. Then we will talk about the D3. This is the D3, which gets inserted to the same middle finger proximal phalanx. D2 and D3 both get inserted to the middle proximal phalanx of the middle finger. Okay. Then we have the D4. It gets inserted to the proximal phalanx of the ring finger. Okay. These are the dorsal interossi. So you know about the dorsal interossi and the palmar interossi now. Okay. On which fingers the insertions of dorsal interossi are absent? So we have the little finger, in which no dorsal interossi is attached, and we have the thumb also, in which no dorsal interossi is attached. Okay, present is there but not attached. but in middle finger we have attachment of the two dorsal interossi. Okay, so these are all about the palmar and the dorsal interossi, the lumbricals. So let me revise the muscles of the hand quickly, very quickly, by this note. Muscles of hand are 20. Thinner, hypothinner lumbricals and interossi. Thinner muscles are 4. Okay, thinner muscles are 4 in number. Okay, so what are the thinner muscles? We have adductor pollicis brevis, the flexor pollicis brevis, the opponens pollicis, and adductor pollicis. Here are the opponents, the abductor pollicis brevis, the flexor pollicis brevis, and the big muscle adductor pollicis is a transverse and oblique head. Okay, then we have the hypothinner adductor digiti minimi, flexor digiti, ODM, and PB. Palmaris brevis, the subcutaneous muscle. This is all are present here. Okay, 4 lumbricals, L1, L2 are unipinnate, supplied by median nerve. L3, L4 are bipinnate, supplied by ulnar nerve. Okay, so L1 is this, attached to the dorsal digital expansion of ED tendon. All are inserted to the dorsal digital expansion of ED tendon. L2 is unipinnate, attached here. L3 is bipinnate, so attached here, and L4 is bipinnate, attached here. Then we have the interossi, 4 palmar, 4 dorsal. Palmar help in adduction, dorsal help in abduction. All are supplied by the ulnar nerve. That's why ulnar nerve is called the musician's nerve. We have palmar interossi, 1 that is attached to proximal phalanx of thumb, 2 which is attached to the proximal phalanx of the index finger. There is no palmar interossi on middle finger. We have 1 palmar interossi on attached to the proximal phalanx of ring finger, and 1 to the proximal phalanx of little finger. In dorsal interossi, which are bipinnate, we have 4. D1 which is attached to the proximal phalanx of the index finger. D2 is attached to the proximal phalanx of the middle finger, and D3 to the proximal phalanx of middle finger. So there are 2 dorsal interossi attached to the middle finger, and D4 which is attached to the proximal phalanx of the ring finger. Okay, so these are all about the muscles of the hand. Okay, so let's discuss about the spaces in hand. Okay, this is also a topic. So we have 4 type of spaces in hand. One is called as the thinner space, the mid palmar space, the pulp space, and 4th one is the forearm space of Parona. Okay, let me draw the bursas first. So we have some bursas in the hand. Okay, let's say this one, little finger, ring finger, middle finger, the index finger, and this. Okay, so we you have the tendons of FPL and FDS and FDP. Okay, let's say these are the tendons of FDS and FDP. I have overlapped them both. These are the 4 tendons of FDL and FDP and the tendon of FPL. Okay, these are the tendons of FDL and FDP. Fine. With this, let's look at some of the bursas, the radial bursa and the ulnar bursa. Okay, so this bursa which covers this one, the tendon, this tendon, and some parts of this tendon extends like this one. Okay, this one is a bursa, the red part is a bursa which is called as the ulnar bursa. Okay, then we have the bursas around this also. This have also bursas, and another bursa which surrounds the tendon of FPL, as we saw in that Flexor retinaculum diagram. We have here the radial bursa. This green one is the radial bursa. Okay. So question is there, why it is safe to prick these 3 fingers only. We don't prick this little finger and the thumb because there is continuation of the bursas. Okay, the ulnar bursa is continuated downwards and radial bursa downwards. So it is if the infection occurs in this bursas, if we prick the fingers, then the infection may travel downwards, transverse downwards. So we don't prick this. These 3 fingers are safe to prick. Safe to prick. Okay, did you understand? Then we'll take a transverse section of hand at this level. Okay, and look at all the spaces in more detail. Okay, this diagram is very important, so please see this in detail. So first we will draw the phalanges. Okay, so let's draw okay, let's say this is 1, this is 2, 3, 4 and 5. Okay, so we have the hypothenar eminence here, we have the hypothenar eminence here, hypothenar eminence here, and we will have the thenar eminence here. So we have the thenar eminence. Okay, so TE, as this is a thumb, you know. Okay, after this let's draw the hypothenar eminence a bit small so that our diagram gets anatomically correct. Okay, so after this let's draw the interossi muscles here also. So to 1, what is attached? The palmar interossi are attached to 1, 2, 4 and 5. As we said that the ring finger does not have any palmar interossi. So here we have the palmar interossi of 1, 2, not 2, 3, 4 and 5. And then we have the dorsal interossi which are attached to all between the 4. Okay, so this is complete now. Then we have to draw a septum. Okay, then we have to draw a septum. We have 2 septums. One is the medial septum and one is the lateral septum. So the septum covering this is called the medial septum. This is the medial septum here. Okay, it will go like this and form a space. Okay, form a space and like this, and this is the lateral septum which will cover the thenar eminence. Okay, we know to third metacarpal, the middle finger, the transverse side of adductor pollicis is attached. Okay, so this is the transverse head of adductor pollicis. Okay, and there is the flexor retinaculum also. The flexor retinaculum will not be visible here. The only thing that will be visible will be the palmar aponeurosis here. Okay, this is the palmar aponeurosis. I will draw it in another color. Okay, this is the palmar aponeurosis here, palmar aponeurosis. Okay, and from the palmar aponeurosis to the third phalange, there would be a septum extending, which is called as the intermediate septum. Clear? Okay, so we have we can see 2 spaces here. Okay, first let's draw the tendons. Which tendons would be visible here? If you can relate the tendons 1, 2, 3 and 4. Okay, these are the tendons of FDS. Yes, FDS tendons will be visible here, and there will be the tendons of 1, 2, 3, and 4. These are the tendons of FDPS. FDP tendons would be visible here. Okay, to FDS and FDP tendons, what muscles are attached? The lumbricals. Okay, so we'll draw the lumbricals here. Here is the lumbrical 4. So I will just write the number here 4. Here is the lumbrical 3 attached. Lumbrical 2 is unipinnate. So 2, and lumbrical 1 is also unipinnate. So 1 lumbricals are attached. And here we have FPL. Here we have the tendon of FPL. Okay, here we have the tendon of FPL. So these are the things which you need to understand in this diagram, and I hope by the discussion of the muscles of hand you can clearly appreciate this diagram. Okay, how the lumbricals and the other muscles are attached. If you can get the orientation, please see that this is the anterior part. Okay, this is the posterior. The lateral is this, as the thumb is present there. No, medial is this. Okay, we can see two spaces here. This space is called as the mid palmar space, as I wrote earlier. Okay, mid palmar space, and this space which is here is called the thenar space. Okay, as I mentioned here. Okay, this is the mid palmar space and this is the thenar space. Okay, clear? Okay. There are two clinically important points here, that thenar space communicates with facial sheath of L1 lumbrical. Okay, thenar space and L1 lumbrical, the sheath of L1 lumbrical are just connected, are communicating. Okay, so any infection in thenar space, if it is if any infection occurs in the thenar space, then can be drained by putting the incision should be put on first web space. If you put the incision of first web space, then it will pierce the sheath of L1, and if it pierces the sheath of L1, as L1 and thenar space are communicating, you can drain the infection easily. Like that, the mid palmar space communicates with the facial sheath of L2, L3, L4. Okay, so if you want to drain the infection on mid palmar space, then you can put an incision on third and fourth web spaces. So as to drain any infection in the mid palmar space. Okay, I hope you understand. The mid palmar space also communicates proximally to the forearm space of Perona. Actually, the forearm space of Perona, that is the space between FDP, FPL and pronator quadratus. You don't need to just know in detail about the forearm space of Perona. Just know that it communicates with the forearm space of Perona. Okay. Next we want to talk about the pulp spaces of fingers. Okay, we have the fingers, the phalanges. So we have the pulp spaces. Okay, let's draw the phalanges. Let's say this is your finger. Okay, you have the nails here. Okay, this is your a finger. Let's say the index finger. These are the small bones of the finger, the phalanges. This is the distal phalanx. Okay, as it is the digit, we have the digital artery draining here, digital artery supplying here, digital artery which will supply this small bones. Okay, So pulp spaces extend from here. So we have some pulp spaces here. Pulp spaces would not extend to the the artery would supply the base of epiphysis, the base of the distal phalanx, but this part would not be present in the pulp space. Okay, so pulp space would be this one, this one, this one, this one, and this one. These are the pulp spaces. Okay, these are the pulp spaces, and these septums are the connective tissue septums. Connective tissue septums. Okay, so these are the pulp spaces. Any infection in pulp spaces, the pulp space infections are called as the Whitlow or Phelan. Whitlow and Phelan are the infections of pulp spaces. Okay, avascular necrosis of distal 4/5 of terminal phalanx is called as Whitlow. Okay, in Whitlow what happens? There is avascular necrosis due to deficient blood supply, that the tissue is necrosed or died of distal 4/5 of distal phalanx. Just I want to say this part, this whole part, 4/5, not the 1/5 that is lying not in the pulp spaces, but the part lying in the pulp spaces. This whole part is avascularly necrosed, this part. Okay, so this is Whitlow, and Phelan is also a pulp space infection. Okay, next we have to talk about the arterial supply of the palm. Okay, so we have two palmar arches, arterial arches or palmar arches. Okay, we have a superficial palmar arch and a deep palmar arch. We have the two palmar arches here present. Let's draw a hand. Okay, let's say this is the hand. So we have to draw the two palmar arches here. Okay, I will use different colors, but know it that these are arteries only. Okay, so just follow with me. It's a little bit tough, but you will understand. Let's say this is the radial artery coming over here. Radial artery, one branch will go here, the branch that will be present in the anatomical snuff box. Yeah, do you remember? Is the content of anatomical snuff box here. The superficial branch of radial artery would come like this. What is this? Superficial branch of radial artery. Okay, this is there, and the radial artery will wander around and appear here over the snuff box. Okay, and would divide into the deep okay, it will come over here and would form the princeps pollicis artery, and it would give a branch, that is deep branch of radial artery. This is the superficial branch of radial artery. Okay, and the deep branch would give a branch to this index finger, that is called as radialis indicis artery. Okay, understood? So this is the whole supply of your radial artery. Let's talk about the ulnar artery. Let me draw the ulnar artery in not blue, not green also, because these are the general color combinations of different structures, so you may just confuse of being a vein or something. Okay, let's say this is the ulnar artery. Let him come. This would form a arch like this here. This is the superficial branch of ulnar artery. This is the superficial branch of ulnar artery here, and this is the deep branch of ulnar artery. This is the deep branch of ulnar artery that would complete this arch. Okay, and that would give branches also to this phalanx, then a separate branch, then a division branch to this, another divisible branch to this, and another divisible branch to this also. Okay, so this is the whole arterial that apply of the palm. This arch which is formed, this whole arch is called as the superficial palmar arch, SPA. Okay, and this whole arch that is formed is called as the deep palmar arch. Okay, did you understand how the superficial and deep palmar arches are formed? Okay. Okay, we have some names also. This is P. What is P? This artery is P. What is P? This is the proper digital artery. Okay, and the arteries that are dividing are called as C. That is common digital artery. Okay, you should know them. And index finger is a radialis indicis, which is a indicis artery, which is a branch of radial artery, and a princeps pollicis also, which is a branch of radial artery itself. Okay, so superficial palmar arch is formed by the superficial branch of ulnar artery plus the superficial branch of radial artery. Okay, and the deep palmar arch is formed by the deep branch of ulnar artery plus the deep branch of radial artery. Okay. Okay. Yeah. So let me give an overview of this structure, like the arches again. Okay, let's do it again, because when you do it again, you tend to remember more. So this was our hand. So I'm drawing it in a very rough fashion. This was our hand. So we have the radial artery coming over here. The radial artery will go and come back in the anatomical snuff box. It will give a branch to this. This is called as princeps pollicis, and it will go to the index finger also, that is called as radialis indicis artery. Okay, and then it will form it the part of the deep palmar arch, the deep branch. This is a deep branch. Okay, and it will give a superficial branch too. The superficial branch would come here. This is the superficial branch, and then we have the ulnar artery, which will draw in blue. Okay, this is the ulnar artery. Ulnar artery will give a deep branch. This is a deep branch of ulnar artery, and the superficial branch would complete the structure here. This is a superficial branch, and it would give a proper digital artery and another common digital artery, another common digital artery, and another common digital artery. Okay, so these are the arches of the hand. This is the superficial palmar arch, and this second one is the deep palmar arch. So deep palmar arch. Okay, if you understood up to this, let's move on to nerves. Okay, so we'll move on to the nerves. So are you guys ready to learn about the nerves? So we have to discuss the 3 nerves and the associated the diseases also along with them. The first one is the radial nerve. The first one is the radial nerve. The root value is C5 to T1. Okay, the root value is C5 to T1. You may recall all the root values that are of your brachial plexus. Okay. Okay. So what is the course of radial nerve? Starts from the posterior cord of brachial plexus. You must have remembered lunar. What was R? Yes. Posterior cord of brachial plexus, lunar. Starts from here. Goes via the lower triangular space of scapula. Lower triangular space of scapula. You know about the scapular spaces. This was the humerus, the scapula, and the spaces here. Pectoralis minor here, pectoralis major here, the long head of triceps here. Okay, this was a quadrangular space, the lower triangular and the upper triangular spaces, and here we had the radial nerve present in the radial groove. Okay, then from lower triangular space of scapula it arises and wounds around the spiral groove of humerus, spiral groove or the radial groove of humerus. If you have a humerus present with you, please see there is a spiral marcation or the demarcation present over the body of the humerus in a radial fashion, that is called the spiral groove of humerus. Then it comes to the lateral aspect of arm, pierces the lateral intermuscular septum. It pierces the lateral intermuscular septum, pierces and descends in front of septum. It descends in front of septum and reaches in front of lateral epicondyle of humerus. Okay, reaches in front of lateral epicondyle of humerus. Then it divides into two branches, that is superficial branch and a posterior interosseous nerve. Okay, posterior interosseous nerve. You must have remembered the posterior interosseous nerve was the component of, please comment. I said which component of extensor retinaculum? Please comment. In the superficial branch of radial nerve, it is present where? It is in the cubital fossa. Okay, it leaves the cubital fossa and passes deep to brachioradialis. I said when I taught brachioradialis today, I said that deep to brachioradialis, the superficial branch of radial nerve and the radial artery gets present. Okay, then it goes to the roof of the anatomical snuff box. I said in the roof of the snuff box, and it supplies the skin on lateral 3/2 of dorsum of hand and fingers. Okay, it supplies this part. You may draw this diagram here. If you have the hand, it will supply this part, this whole part. Okay, this is the lateral 3/2, except the nail beds. Nail beds are not supplied by it. Okay, nail beds are supplied by the median nerve, but radial nerve supplies the dorsum. Dorsum is the posterior part of the your that is hand. Okay, this is the lateral 3/2 of the dorsum of the hand. Okay, then we have the posterior interosseous nerve too. Posterior interosseous nerve passes between the lamina of supinator muscle. Okay, between the lamina of supinator muscle, then it runs behind interosseous membrane, and supplies to whom? Supplies the extensor compartment of forearm. All the muscles that are present in the extensor compartment, it supplies them. Okay, so this is the whole course of the big nerve, that is radial nerve. Okay, now we'll discuss a diagram here. Let's say this is the humerus. Let's say this is the lateral epicondyle here and the medial epicondyle here. Okay, we have a groove here called as the spiral groove here, and the nerve we will mark in purple. Let's say purple. Okay, It goes like this, like this, like this, like this, and descends in front of the lateral epicondyle, divides into this PIN, posterior interosseous nerve, and into the superficial branch of radial nerve. Okay, the superficial branch of radial nerve supplies the lateral 3/4 of the dorsum of the hand and fingers except the nail beds, and the posterior interosseous nerve supplies a host of muscles, the extensor compartment, all the extensors, ECRB, EPL, EPB, EI, extensor digiti minimi, extensor digitorum. Okay, all the extensors. Clear? Let's say what are the branches here? This is present in axilla. Okay, if this is present in axilla, this is the axilla, this whole region. Okay, it will give a branch to the triceps muscle, the long and the medial head of triceps. It also supplies the long head and the medial head of triceps. Then from the point B in the spiral groove, it gives branch to triceps. Which head? Medial head and the lateral head. So the medial head of triceps is getting two innervations here. Okay, and triceps and anconeus too. Okay, then here we have the lateral intermuscular septum. It will pierce and come in front of the lateral epicondyle. So here we have two branches here. This branch is to brachioradialis and this one to extensor carpi radialis longus. Okay, ECRL and brachioradialis. Okay, these two branches are given here, and this is the lateral epicondyle. We know this will go between the two lamina of which muscle? Supinator. This is the posterior interosseous nerve and this is the superficial branch of radial nerve. Okay, so this you understood what are the branches which are given in the axilla. In the axilla there is long head and medial head of the triceps. Okay, and in the spiral groove it will give branch to triceps and anconeus. The medial head will be given again, and the lateral head. This is lateral head and this is the longitudinal head. Sorry, the long head. Okay, long, not longitudinal head. And the intermuscular septum, it will pierce the intermuscular septum and come. This is the lateral intermuscular septum, LIMS. Give branch to brachioradialis and ECRL, and the posterior interosseous nerve will give innervation to all the extensors compartment of forearm, and the superficial branch will give innervation to the dorsal 3/2 of the hand and fingers, the palm and the fingers except the nail beds. Okay, then we want to learn about the injuries, where the injuries are commonly occurring in case of your radial nerve, and what are the effects. So let's say the radial nerve is injured in axilla, let's put it 1. If it is injured in spiral groove, let's put it 2. If it is injured here in front of lateral epicondyle, like in lateral epicondyle fractures and all, let's put it 3. And if it is injured in here just below the supinator, let's put it 4. Okay, so we'll discuss all the 4 injuries here. The first injury of radial nerve in axilla will cause a disease called as the Creutz's palsy. I said yesterday that Creutz's palsy is due to the radial nerve injury in your axilla. Okay, what will happen due to this? Because the triceps will be paralyzed. Will whole the triceps be paralyzed? No, not the whole. The partial paralysis of triceps will result in flexed elbow. Okay, because triceps is an extensor, so flexed elbow will be occurring. Due to paralysis of extensors of wrist, all the extensors of wrist will be paralyzed. You just see that if this is injured, the whole course will be injured, affected. So all the extensors will be paralyzed. So that will be wrist drop, wrist would droop, or the wrist flexion, also called as the wrist drop. Then the fingers would drop. There will be the finger drop. Why will the finger drop? Due to paralysis of extensor digitorum. Extensor digitorum is also supplied here now. Finger drop. And there will be sensory loss. Sensory loss of what? Sensory loss of lateral 3/2 of dorsum of hand. Why? Because the superficial branch of radial nerve is also lost in this. Okay. So these are the features of your crutch palsy. And the people holding crutches, okay, beneath their axilla, they would suffer from crutch palsy. So the name comes from the crutch that are held by those who are suffering from rheumatoid arthritis and all. Okay. Then the second one is the Saturday night palsy. Or the honeymoon palsy. In this, people are generally drunk on the Saturday night. They would sleep like that, inclined in the armchairs. I had a picture. I showed a picture in yesterday class. Please refer that, or you can search up a person like that. Okay, or due to a person sleeping over someone's arm. Okay, so it is called Saturday night palsy or honeymoon palsy. Edge of OT table in operation patients, like if a patient is operated and the OT table they are laid like hands like that. Okay, the person is like so edge of OT table can also cause compression of the radial nerve. This is due to compression of radial nerve in spiral groove. Okay, in spiral groove. So this in this the triceps would be paralyzed. Maybe I said wrong that there is the whole paralysis. There is the whole paralysis of triceps here, because all the heads of triceps are like there now. But in Saturday night palsy, the triceps would be paralyzed, but there will be partial. Why there would be partial? Because the long head and the medial head would be supplied in axilla only, would be given branches in axilla. This is not affected. From this level, the things are affected in Saturday night palsy. Okay, so in this triceps would be partially paralyzed, axilla is not involved, so there will be weakness in elbow flexion, weakness in flexion, extension, because triceps is an extension now. And other features would be there, like wrist drop would be there, finger drop would be there, and sensory loss would be there. Other features of that crutch palsy will be there. Okay, so let's come to the third point, the third region where it can be injured. This one, above the lateral epicondyle. Okay, this can be result of fractures. So due to this epicondylar fracture, the lateral epicondylar fracture may damage the radial nerve. So in this, which muscles are spared? You can see the triceps is spared, the anconeus is spared. Okay, and the ECRL is also spared. The ECRL, brachioradialis, these are also spared. Okay, so in this the muscles are spared. As ECRL is spared, so there will be no wrist drop. There will be no wrist drop. Okay, and as the triceps and anconeus are spared, there would be no problem in extension, so the person can perform the extension very easily. But finger drop would be present. Why finger drop would be present? Because of course the extensor digitorum that is supplied by pin is lost, okay, paralyzed, and there will be of course sensory loss also, okay. Sensory loss will also occur due to the injury of superficial branch of radial nerve. Then we can have the fracture of head of radius fracture. In head of radius fracture, this fourth part is the head of radius. So the superficial branch is also spared, the muscles above them are also spared, okay. The only thing that is affected is posterior interosseous nerve, okay. Due to the fracture, only finger drop will occur, because all are spared, only PIN is affected, so only finger drop will occur. Why finger drop will occur only? Because due to involvement of extensor digitorum, okay. Superficial branch is spared, so sensory loss would not occur, only finger drop will occur. So you have to just remember the features of all this, the injuries of all this. If I quickly repeat the course of radial nerve: posterior cord, lower triangular space of scapula, the spiral groove, then to the lateral aspect of arm, pierces the intermuscular septum, descends in front of the septum, reaches in front of the lateral epicondyle, divides into superficial and PIN. Superficial branch leaves the cubital fossa by passing deep to the brachioradialis. Then it appears on the roof of the snuff box and supplies the skin on lateral 3 up, dorsum, hand and fingers except the nail beds. And the PIN, it passes between the lamina of supinator muscles, runs behind the interosseous membrane and supplies the extensor compartment of the forearm, okay. So this is the whole part, and the branches I have discussed already. So after the radial nerve, we will move to the median nerve, okay. So let's discuss about the median nerve. Which the root value is C5 to T1. Median nerve is also called as the eye of the hand, because it is very important for the hand. It is the main nerve supplying the hand, okay. Median nerve also called okay. From where the median nerve arises? The median nerve arises from the lateral that root, median root and lateral root together form the median nerve, okay. So median nerve actually is present laterally to the axillary artery, but it crosses to the medial side of the axillary artery where it becomes the brachial artery, okay. So it is medial to brachial artery in the cubital fossa, but it is lateral to the axillary artery, okay. So just you can write the course. Where its originates from medial cord and lateral cord of brachial plexus. Then it descends lateral to brachial artery, descends laterally to brachial artery. Then it crosses from lateral to medial side of brachial artery, okay. Then it becomes the medialmost content of cubital fossa, okay. Please remember the medialmost content of cubital fossa was median nerve. Then it leaves the cubital fossa by passing between two heads of pronator teres. Pronator teres had two heads, so it passes between the two heads of pronator teres. Then it passes deep to FDS, okay. Flexor digitorum superficialis, and divides into two parts. A branch is given here that is called as anterior interosseous nerve. Posterior interosseous nerve was a branch of your radial nerve, but anterior interosseous nerve is a branch of median nerve. So anterior interosseous nerve supplies the deep muscle of anterior compartment, The flexor pollicis, flexor digitorum profundus, the flexor pollicis longus, and the pronator quadratus, anterior compartment of forearm. Okay, and as it passes deep to FDS, it supplies the flexors, supplies superficial flexors. It passes 5 cm proximal to flexor retinaculum, superficial to flexor retinaculum. Okay, then it emerges lateral to FDS tendon. Then it passes deep to flexor retinaculum. A superficial branch is also there. Okay, then in the hand it divides into a medial branch and a lateral branch in the hand. Okay, so this is the whole course of your what you can say, the median nerve. Okay, this is the whole course of your median nerve. So let's discuss the median nerve along with a diagram. So let's discuss first the course of median nerve in hand. Okay, so we want this diagram now. The diagram I am copying and pasting here is this diagram we need now. So this whole diagram I am copying here, as it is the main nerve of hand, so we have to see this diagram, of course. Let's complete it somewhere. Okay, so median nerve, I am drawing it with some unique color, like I have used all the colors perhaps. Let's draw it with orange. Okay, follow this orange. So this is the median nerve which is coming here. It will give a median division. Okay, it will give a median division and supply the digits. This means the digits, and another branch of median division would supply the L2 lumbrical. This will supply the L2 lumbrical. Okay, then it would give a lateral division. This is the lateral division. The lateral division would supply all the muscles of the thinner eminence, the flexor pollicis brevis, the adductor pollicis brevis, and the opponens pollicis. Let's say these are the three muscles here of the thinner eminence which would supply these three muscles. Okay, and would, lateral division also supplies the L1 lumbrical. Okay, also supplies the L1 lumbrical, and another division of lateral division, another branch that will supply the digits. Okay, so if you understood what are the things supplied by this. So flexor pollicis brevis, this is the flexor pollicis brevis now. Flexor pollicis brevis, the deep head is supplied by ulnar nerve sometimes. Okay, you don't need to remember this as such. Just say flexor pollicis brevis is supplied by your median nerve. Okay, so this is the course of median nerve in the hand. So what I said, the course of median nerve in the hand. So median nerve comes, divides into a medial division and a lateral division. A medial division, it supplies the digits. It would come down and supply the L2 lumbrical. The lateral division, it would go and supply all the three muscles of the thinner eminence muscles. Okay, another division would supply the L1 lumbrical, and another division supply the L1 lumbrical, and another division supply the digits also. Okay, this is the course of median nerve in hand. Let's draw a schematic diagram again. So this let this be the humerus. So median nerve will pass like this. Okay, between the two heads of pronator teres, and will divide into anterior interosseous nerve and will drop down here. Anterior interosseous nerve would supply the FDP, the lateral half of FDP. Okay, and this would drop down and pass deep to the flexor retinaculum. Okay, this part will pass deep to the flexor retinaculum, and a part would be superficial to the flexor retinaculum, okay, which is called as the palmar cutaneous branch. Then we have the digital branch, and this branch will supply the thenars L1, L2, which I drew here. This one, this is the branch. Okay. So if you could relate this thing with the course, so origin is medial cord and lateral cord, descends lateral to the brachial artery, then crosses to the lateral to medial, then becomes the medial most content of cubital fossa, leaves cubital fossa between two heads of pronator teres, passes deep to flexor digitorum superficialis, where it divides into anterior interosseous. Anterior interosseous nerve supplies the deep muscles of anterior compartment of forearm. If I give an example, the flexor digitorum profundus, FDP profundus, the lateral half of flexor digitorum profundus, and another branch supplies the superficial flexors. It passes 5 cm proximal to flexor retinaculum, descends lateral to flexor digitorum superficialis tendon, passes deep to flexor retinaculum, and divides into medial branch and lateral branch, where we can see the course here. The medial branch giving a branch to the digits, another branch supplying the L2 lumbrical, and the lateral division giving 3 branches to the thinner muscles here, and one to the L1 lumbrical and another to the digits. Okay, and the branch which passes superficial branch of the median nerve, which passes superficial to the flexor retinaculum, is called as the palmar cutaneous branch. Okay, and the if I show the portion of hand that is supplied by the palmar cutaneous branch. So let's say this is the hand. Let's say this is the hand. So this whole portion, this part, is supplied by the palmar cutaneous branch. Okay, and these all parts, this one would supply the digits, the digital branches supply the digits. So this is the yellow region that is supplied, and palmar cutaneous branch is supplied by the pink. Okay, so let's say we have some injuries at some points here. We will use the same diagram for injuries. Let's discuss the injuries of your ulnar nerve also. So we can have either higher injury or lower injury. So if injury occurs here in the condyles of the humerus, between the condyles of humerus where it passes, so I give the name A. And if injuries occur at flexor retinaculum, so let's say it's B. So one was higher injury. So what may be the causes of the higher injury? Some supracondylar fractures may occur, or you can have pronator teres syndrome. Okay, you can have pronator teres syndrome, or you can have your Struthers ligament. What is Struthers ligament? Struthers ligament is an additional head of coracobrachialis. Coracobrachialis can have an additional head which extends up to medial epicondyle. So median nerve can pass deep through the Struthers ligament. So Struthers ligament basically an additional head of coracobrachialis by which median nerve can pass deep to it, and if it is compressed, then it can cause the higher injury of your median nerve. So in all three of these, in the higher injury, the opponent's policies is involved. Of course, opponent's policy is supplied by the lateral division of median nerve in hand. So opponent's policies is involved. So due to opponent's policies, you can have an unopposable thumb, that is called as ape thumb deformity. Ape thumb deformity. Okay, you can have an ape thumb deformity. In this also, what is paralyzed? FDS is paralyzed. Okay, and lateral half of FDP is also paralyzed. So if this is paralyzed, the patient cannot flex his index finger. Patient can't flex index finger. So you can ask the patient to make a fist. If he can't flex his index finger, then like this, if he'll do make a fist, then the index finger will point out. So pointing index finger is an indicator of higher median nerve injury. Higher median nerve injury. Okay. Then we will discuss about the lower injury. Let's say about the carpal tunnel syndrome. So carpal tunnel syndrome is also an example of lower injury. A most common cause of lower injury is carpal tunnel syndrome only. So what are the features of carpal tunnel syndrome? You can write this. As the injury occurred here, what is spared? So this AIN is spared, the FDP is spared. Okay, but what is affected? The deep branch, this digital branches and palmar, the branches of median nerve, which is below the palmar aponeurosis, the flexor retinaculum is affected. Okay, so opponent's pollicis is paralyzed. Yes, opponent's pollicis is paralyzed. So ape thumb deformity is common. So in both A and B, lower injury or higher injury, in any median nerve injury, in fact, the ape thumb deformity is a cardinal feature. Then no effect on FDS and FDP. FDS and FDP are intact. No effect, they are working fine. Okay, the palmar cutaneous branch is not affected, as it passed superficially to flexor retinaculum. So there is no sensory loss. The digital branches are affected, but digital branches are affected. So if you want to distinguish between lower injury and higher injury, you can use this pointing index finger test. Pointing index finger test to distinguish between the lower injury and the higher injury. Okay. With this, let's move on to the your next nerve, that is your ulnar nerve. Okay, let's talk about the ulnar nerve. Here the root value changes for median nerve and your radial nerve. The root value is C5 to T1, but for ulnar nerve the root value is C7 to T1. From where it arises? The medial cord of brachial plexus is where it arises. Okay, it continues medially to brachial artery. Which one was passing laterally to brachial artery? The median nerve. Okay, and ulnar nerve passes medially to brachial artery. It pierces medial intermuscular septum, MIMS, medial intermuscular septum, and reaches behind medial epicondyle. Okay, your radial nerve was reaching in front of the lateral epicondyle, but median nerve, ulnar nerve reaches beneath the medial epicondyle. Okay, then it passes between two heads of FCU, flexor carpi ulnaris. It passes between the two heads of FCU. Okay. Then it descends between FDS and FDP in same medial side, medial to ulnar artery, and then it passes superficial to flexor retinaculum, divides into small superficial branch and a deep branch. Okay, the superficial branch of the ulnar nerve, it supplies the palmaris brevis muscle, and the deep branch, it supplies the all the hypothenar muscles. It supplies L3 and L4 lumbricals. It supplies all the palmar interossi. It supplies the second, third and fourth dorsal interossi also, and it also supplies the adductor pollicis. Adductor pollicis is the last muscle. It supplies the adductor pollicis. It is the last muscle to be supplied here. Supplied by ulnar nerve. Okay. So adductor pollicis generally it belongs to your thinner eminence, but not to thinner eminence, but thinner muscles. But it is not supplied by the median nerve. It is supplied by the ulnar nerve. Okay. It also gives a branch to your flexor pollicis brevis deep head. Okay. I said sometimes ulnar nerve supplies the deep head of flexor pollicis brevis. Okay. And this is the whole course of your this nerve. If you want me to draw the course also, you can draw it. Let's say this is your humerus. This is the medial epicondyle, this is lateral epicondyle. We draw the nerve in pink. So here we have it will pass deeply to medial epicondyle. Okay, deeply it will come down here as like this. Okay, and let's see, here we have the flexor retinaculum. It will pass deeply, it will pass superficially, sorry, flexor retinaculum, and it will divide into deep branch and a superficial branch here. If you want me to visualize the arteries also, then this is the brachial artery dividing into radial artery here and the ulnar artery. So it will pass just medially to the ulnar artery in its whole course. And here we can have the two heads of FCU, where it passes between the two heads of FCU. Okay. So here we have the two heads of FCU which form a tunnel. This tunnel is called as the cubital tunnel. Cubital tunnel. So if the ulnar nerve is injured in the cubital tunnel, it is called as the cubital tunnel syndrome. So you might have heard about cubital tunnel syndrome too. If I talk about the branches, it will here it will branch to FDP, the medial half. FDP lateral half was supplied by which nerve? The median nerve. Okay, FDP lateral half was supplied by the median nerve, and the medial half is supplied by the ulnar nerve. Okay. If you want me to draw the diagram of your hand, like what are the structures that are supplying, you can take this diagram, but this diagram is complicated a bit. No problem, you can make another. So I will draw 1, 2. I'm drawing the phalanges quickly. 3, 4, 5, because we tend to remember more if we just draw the diagrams. Okay, so here we can have 3 muscles, adductor digiti minimi, flexor digiti minimi, and opponens digiti minimi. Okay, 3 muscles are shown here. You can have your lumbricals here, 1, 2, 3 and 4, not attached to any 3, and 3 we have the the adductor pollicis. This is the adductor pollicis here, and you can have 3 muscles here. Okay, the thinner eminence, and you can have the tendons too. This 4 tendons. Okay, and the lumbricals attached to them. Okay, this is L4, L3, L2, L1. L2, L1 are supplied by which nerve? Look here, I said the median nerve supplies the L1 and L2 lumbricals, but the L3 and L4 lumbricals should be supplied by the ulnar nerve. Okay, so let me draw the course of ulnar nerve now, if you are ready with the diagram. So let's say this is the ulnar nerve. Here you have the deep branch here. This is the deep branch, and superficial branch will supply only one muscle, that is palmaris brevis. Okay, the deep branch would come like this. Okay, we just crossed our limits like this. Superficial branch, deep branch would give innervation to all the hypothenar muscles. Okay, and then it will pass like this. Okay, I said it will pass between the two heads descent between the FDS and FDP, medial to ulnar artery. Okay, superficial branch and deep branch will branch pass like this and supply the adductor pollicis. Okay, adductor pollicis is the last muscle to be supplied, and it will give some smaller branches to which muscles I am marking. It will give branch to L4 lumbrical, to L3 lumbrical. Okay, it will give branch to this lumbrical also, to the interossei. So I have not drawn the interossei. Let's draw the interossei. This is the interossei, this is the interossei. Interossei. Okay, it will give branch to the interossei to the lumbrical, and the interossei to the lumbrical. Okay, and the second one also will give branch to interossei and the lumbrical, and the first one only to the lumbrical. Okay, and it will also give a branch to your flexor digitorum, flexor pollicis brevis, FPB, not to the adductor pollicis brevis, only flexor pollicis brevis deep head it will give a branch to. Okay, and if you want to talk about the cubital tunnel syndrome also, so cubital tunnel syndrome is due to compression of ulnar nerve between heads of flexor carpi ulnaris. Heads of flexor carpi ulnaris form the cubital tunnel. Okay, so it is the compression of ulnar nerve, importantly remember. Okay. So what will occur here? There will be paralysis. What paralysis will occur? The medial half of FDP. Okay, which muscles? The hypothenar muscles. Yes, all interossei, the adductor pollicis, and which lumbricals? L3 and L4 lumbricals. All these would be paralyzed. Okay, so if you get a question like this, a clinical case question, that a 36-year man is brought to the emergency department because of a deep knife wound on the medial side of his forearm, distal forearm, medial side. He is unable to hold a piece of paper. He is unable to hold a piece of paper means which muscles help in holding a piece of paper? The interossei. So interossei are paralyzed, and a sensory loss on the medial side of hand. Yes, sensory loss on the medial side of hand. Okay, and little finger also. Which nerve is most likely injured? Okay, so palmar interossei paralyzed. So there should be for holding a piece of paper, we should adduct. Okay, adduction. Adduction is lost. Which interossei do the adduction? The palmar interossei. Which nerve supplies the interossei? Interossei are supplied by the ulnar nerve, so it is likely an ulnar nerve injury. Okay, got it. So with this we finish up your upper limb in 2 videos. It has been a long lecture today, but I hope all that made sense. All these topics made sense. We discussed the 3 important nerves. Please read the 3 important nerves and repeat the courses. You must know all the courses because injuries are common in your clinical practice also. So we learnt about the shoulder joint, the elbow joint, and after shoulder joint we went to the elbow joint. Then from elbow joint we went to the forearm muscles. There are many forearm muscles. Okay, then we went to the pronation, supination, the anatomical snuffbox, extensor retinaculum, flexor retinaculum. Discussed your hand muscles. We discussed all your hand muscles, spaces of hand and your pulse spaces and all. Then we discussed the arches of hand. We discussed the 3 important nerves: the radial nerve, the median nerve, and the ulnar nerve, along with their injuries and clinical associated anatomies. Okay, so with this we complete the chapter. The lecture 3 would be an extra edge. I will bring more tomorrow. There will be lecture 3 and we will discuss the cadaveric images and some associated clinicals too for an extra edge in your exams, for your next and PG exams. So there will be cadaveric images discussion, and I'll say the tricks how to identify the cadaver, the muscles in the cadaver and the nerves and all. So we will incorporate your things that are learnt in your first lecture and second lecture. So get awaited, get tuned, stay tuned, and thank you.